Hello, welcome everybody. My name is John Baker. I'm an interventional cardiologist at Anaheim Regional Medical Center. I'm also the co-chair of the California ACC Prevention Committee, for which Nathan Wong, who we'll talk about in a minute, also is the co-chair. Tonight we're going to talk to you about a great topic. The topic tonight is going to be nutrition and cardiovascular disease. We have two awesome speakers today. First of all, like I said, Dr. Wong is going to be our co-chair. So basically, Dr. Wong is a well-known epidemiologist and a lipidologist. He is the chair of the UCI Prevention Center at UCI for chair of prevention in UCI as well. And our first speaker is going to be Melody Hermel. Melody Hermel is a board certified cardiologist. She's a director of the cardiology in San Diego for United Medical Doctors. She's a cardiologist at Scripps Health. She's also a fellow of the American College of Cardiology and serves on the California ACC Cardiovascular Disease Prevention Committee, as we all do. Dr. Hermel completed her medical degree at Tufts University, her cardiology fellowship at Scripps, and fellowship training in integrative medicine through the Academy of Integrative Health and Medicine. Her work focuses on cardiovascular disease prevention, women's heart health, and evidence-based approaches to nutrition and lifestyle. She's presented her research in national cardiology meetings and has been recognized as San Diego top doctor for 3 consecutive years. Please join me in welcoming Melody Hermel. Melody, take it away.
I think we have to switch slides unless we were planning to have Geeta go first.
Yeah, so Melody, why don't you go first?
Well, I think the order it flows and Geeta's going first. Thank you.
Okay, let's let Geeta go first. So
So
Nathan,
let me briefly introduce Geeta. It's wonderful to have you here tonight with us. I've known Geeta Sikand for about 35 years, since we were both at UCI together many years ago. She is an associate clinical professor of medicine at UC Irvine, also with our Center for Global Cardiometabolic Health and Nutrition. She was also one of the co-founders of our preventive cardiology program. She's a registered dietitian and clinical lipid specialist. She has more than 75 publications in cardiovascular nutrition in various peer-reviewed journals, including the well-regarded Journal of Clinical Lipidology. A few things of note: she was recognized this year as one of America's top 10 dietitians by Today's Dietitian magazine. She's also received special congressional recognition for her leadership, research, and service to the Asian American Pacific Islander multi-ethnic South Asian community, and also has received a Distinguished Scholar of the Year award from the Academy of Nutrition and Dietetics, and other awards as well. But I will stop here, so she will have her 20 minutes. And thank you very much, Geeta, for joining us tonight. And I think you have control of your slides there.
Thank you very much, Nathan. It's wonderful to be here. And as you said, I think both of us came on the Mayflower to UC Irvine in the 1990s, right? And we've been there ever since. So I'm very pleased to be here, and thank you for the generous introduction. One of the first lessons we learn in our dietitian training is that we don't demonize foods. Eating is a pleasure and must remain so. Food is not a villain and must not be demonized. And we dietitians and doctors are not the food police. We partner with our patients in their nutrition journey to personalize their food choices to prevent disease. So with that introduction, let's move forward. These are I have no financial disclosures, so I've listed my non-financial disclosures here for you all. And then my objectives, as well as my outline today for presentation. We've done the introduction, and we'll jump into all the other objectives we have today, which is to discuss the ACC/AHA multi-society guidelines and also the controversial dietary guidelines for Americans. We'll also talk about the FNLA recommendations for nutrition intervention for dyslipidemia in adults, and we'll identify the importance of medical nutrition therapy by RDNs for dyslipidemia management. This is an area where I have personally done the studies, and with Nathan's help and Dr. Moti Kashyap's help, we had the patient database to work with at UCI and the VA Medical Center in Long Beach, and I'll be sharing those studies. And of course, we'll dive a little bit into the clinical and cost outcomes of MNT by RDNs. So moving forward, we're all familiar with this slide. So basically, all I want to say here is that 80 to 90% of heart attacks, heart failures, strokes are preventable if we can work on the diet and the other health risk factors. So we'll tackle some of those today. Tackling all of them is beyond the scope of one lecture today. Getting back to my work in the past 3 decades, many of these were seminal research studies, and others were review articles and meta-analyses, systematic reviews. I'll share those now with you because I'm very proud of our work, and Nathan's been a co-author, and so has Dr. Moti Kashyap. Okay, so we know that dietitians play a key role. Just like for physical therapy, you refer your patients to the PT. Same way for nutrition therapy, you refer your patients to a registered dietitian, nutritionist, or a RDN. This is our newest title. Okay, so let's start with this study that we conducted. It was a meta-analysis, a systematic review, and as you can see, the huge author team, we evaluated 34 primary studies with over 5,700 subjects. And we found that diet counseling by the dietitian led to lower LDLs, triglycerides, blood sugars, A1C, all of the cardiometabolic risk factors that we talk about day in and day out with our patients and amongst ourselves. And of course, we also found an improved quality-adjusted life years and cost savings from the reduced use of medications. So this is a slide that gives you an overview of our study. And as you can see here, the total cholesterol in these 34 primary studies went down significantly. So did LDL, triglycerides, A1C, and BMI. HDLs went up, but that was non-significant, while the other parameters were all statistically significant. And you can also see the quality of life years went 10.75 to 10.78 years up. So it was a good, evidence to show. And these are the forest plot curves that also show the same outcomes, as you can see for LDL cholesterol. All the studies on the left of the zero line, so we know that's beneficial outcome. And so it is for the triglycerides for the most studies. And then here you can also see for weight loss and blood pressure lowering versus controls, because these were all RCTs that you can see how the benefit is on the left of the zero line. So we can see that intervention was very helpful with the dietitian for both of the risk factors here. So the synopsis of this is that when the recent 2026 AHA, ACC, and multi-society, including FNLA guidelines, just came out this year. And I was so pleased to see that they took into consideration our studies, and they made solid recommendations that MNT by RDN is helpful in lipid lowering and can be cost effective. And then Medicare covers, as we know, patients with diabetes and renal disease. And some plans do cover for dyslipidemia, but overall, not all Medicare plans cover for dyslipidemia and for many other risk factors. So we will talk about that in just a couple of minutes. So moving forward, this year we reintroduced the Medical Nutrition Therapy Act, which is the House of Representatives 6199, and the Senate version is 3934. It is a bicameral act, and it will, if it is passed, it will expand access to nutrition counseling by our dietitians for CVD, dyslipidemia, hypertension, obesity, pre-diabetes, and also for the other diseases such as cancer, GI, eating disorders. So what we did is, in collaboration with the University of Michigan Preventive Cardiology Group, they invited me to collaborate with them. We assessed the proportion of Medicare beneficiaries in a university health system who would qualify for MNT or medical nutrition therapy under this expanded coverage. So we looked at a cohort where the Medicare beneficiaries would be identified with encounters or a problem list of all of those 13 medical conditions and diagnosis. And we used ICD-9 or ICD-10 codes to identify the 13 MNT eligible conditions. So it was very interesting when we calculated the MNT eligible patients, and we calculated the MNT eligible patients based on expanded criteria and current criteria, which, as you know, is only the two diseases, which is diabetes and end-stage renal disease. And then we looked at just for CVD and CVD-specific risk factors. So it was very interesting. I'm going to show you now. So within the University of Michigan healthcare system, there were a total of 143,000 plus Medicare beneficiaries. And of course, the age was 70.9, mean plus minus standard deviation, and half female and males. And predominantly white, and some Black, and few Asian. So these current MNT eligible beneficiaries out of these 143,000 plus were 30% of the population based on current criteria, which is those two diseases, right? But the expanded MNT eligible beneficiaries jumped up to 85%. So that makes us think, oh my, what will that do to the cost? So we also made a subgroup of those that would be just CVD and CVD specific risk factors. And then it was 75%. So like just 10% less than the overall. So this is the table from the paper we published in JAMA Network. And you can see before expansion, it's a 30%. And based on all conditions in proposed act, it was 80+%, 88%. And based on CVD, it was 75%. So now the question came up, what about costs? So the Academy of Nutrition and Dietetics, they didn't take our data. They just took from 2023, and they hired Avalier Health, which is a company that does cost analysis, and they use a similar methodology to the Congressional Budget Office methodology. So with that, they estimated that in 2023 dollars, the estimated federal impact would have been $649 million over 10 years. And to us lay people who are not familiar with cost analysis, we might think, oh my God, that's too much. But guess what? It's a drop in the bucket considering what the Congress spends. And then they looked at the cost of inpatient and outpatient visits, and that came to $285 million. Whereas the potential reduction from MNT in inpatient visits and outpatient visits would have gone down to, with 29% reduction, would have gone down to $33 million per year saved. So when you look at this as the bottom line, you're saying MNT services will cost less than 0.06% of the total 2023 inpatient and outpatient cost that is spent on Medicare beneficiaries. So very minimal, right? So that's why we say it's a drop in the bucket if it's approved. Now we're going to switch gears and go to the controversial guidelines that came out in January of this year. They were called the Dietary Guidelines for Americans, and they revised every 5 years. So this year, the pyramid was kind of upside down, as you can see. They put the meat up, and here we've been talking about plant-based, plant-forward diets till we're blue in the face, right? So as you can see here, there was a big reaction from many sources, from many experts, such as the Heart Association clashed about these guidelines, American Society for Nutrition, and so did other schools, including the Academy of Nutrition and Dietetics. I know one of our dietitians, Lucille Farr, she said, these guidelines are laughable. I still remember reading that. And so if you see here, what we had to really look into was what was wrong with these guidelines? Why were they controversial? Well, as you can see in this slide, in that red rectangle, the protein recommendation was very controversial because our, we know that protein is very fashionable, in fact, very sexy to have 100 grams of protein a day when the requirement is in the 50s, right? About 56 grams per day. And so when they recommended the higher amount, it was based on, as you can see, 1.2 to 1.6 grams of protein per kilogram, whereas the National Academy of Sciences recommends 0.8. And there are, no wards, no wings in the hospitals that have protein malnourished patients that I could see and you can see. So another part of the controversy was the fats issue, especially the saturated fats issue. And here again, what we found is when it came to the controversies, they did state eat healthy fats, but then they listed beef tallow and lard and all of these in there. So it was like oxymoronic. On one side, you're saying use healthy fats, and then you're including beef tallow and lard and butter in there. So moving forward, here we go. I want to show you an example. So for example, this is the inconsistency in the saturated fat guidance of the dietary guidelines for Americans. So by flipping the pyramid, what they did is they put fatty red meats on top, they put full fat milk on top, they put cheese and butter on the top as well, right? And yet in the text, they wrote limit saturated fat to less than 10% of calories. That's what I meant, that it's laughable, that it's like an oxymoron here. So the math did not add up because in this example, you can see that on a 2,000 calorie diet, if you're staying under 10%, then you don't want to exceed 22 grams per day. But if you look here, 3 servings a day of dairy, and healthy fat, if you're using just 4.5 teaspoons, that would be 11 grams of saturated fat. And protein foods, if you're using ground beef, 90% lean, for another 4 grams, it adds up to 32. So you can see the math doesn't add up, when you're saying consume less than 10%, but then look what happens when you use the products the DGA recommended. So in summary, what we said was that the implementation of the healthy fats and protein food recommendation could have adverse health consequences. And then, our food industry doesn't care what health issues the customers are having out there. So what they'll do is now they'll take these guidelines and they'll make French fries and chips with beef tallow, right? Because the dietary guidelines said so. And they'll also use protein fortified processed foods like high protein cookies, high calorie nutrient beverages, high protein beverages, but then they're stuck with all that sugar in there as well. So I really like these multi-society guidelines that came out. Now we're switching gears from the DGA, the controversial guidelines, to the legitimate guidelines, as I call the ACC-AHA Multi-Society Guidelines on the Management of Dyslipidemia. So you can see how nicely they did this. They had a whole link to lifestyle management, and this was called the section 4.1.1. And then they went into primordial prevention of dyslipidemia from childhood through adulthood. They went into all the dietary approaches, attainment and maintenance of healthy weight, physical activity, dietary supplements, and also when to refer to a registered dietitian, nutritionist. So now we'll look at that.
You
So
got
one of
about 5 minutes, Geeta, okay?
Okay, thank you. Thank you for that. So the framework of a healthy dietary pattern is to eat more fiber, as we know, adequate protein, but not high, limit saturated fats, sugar, and sodium, limit processed foods, eat a variety of nutrient-dense foods. And remember, food is a pleasure, not a villain, okay? And here we go with the fiber. And I know that Melody is going to take a deep dive into this. So I'm going to move forward from this into this slide here, which is on weight stigma. This is really big right now. In fact, the American College of Physicians came up with a very nice paper just this week, August 6th dated, if you check it out. So patients struggling with weight issues encounter a lot of disrespect, bias, and diagnostic overshadowing. It's very pervasive in healthcare field. And this leads to missed appointments by our patients and misdiagnosis. And of course, there is a failure of these weight loss interventions, which deepens the stigma and erodes the trust. So the bottom line is this stigma, when it accumulates, it becomes emotional dissonance. And the baggage is our patients here, you have obesity as you have failed. And that's creating the very problem we're trying to solve. And now these are the FNLA guidelines. And I just want to share with you these slides because you'll have them at your fingertips. Now, we did divide the recommendations into moderately elevated and severely elevated. And the treatment would depend on that. So in our FNLA guidelines, in which Carol Kirkpatrick and myself, we were the co-lead authors. So it was really a wonderful journey for me. You can see that we had the nuances here, which is we looked at 3 categories of dyslipidemias. We looked at elevated LDL, elevated triglycerides, and with severe triglyceride elevation. And this could be from familial chylomicronemia syndrome, but that's mostly it happens very rare. But there is also multifactorial chylomicronemia syndrome, and that's from lifestyle factors as well. And then the combined dyslipidemia. So again, these slides are there for you. And I'm just going to walk you through that. Your patient may say to you that if I do all you tell me to do, what will that do for me? So you can say to them, even 2 of these 5 interventions could lower your LDL by 6 to 19%. Which is the viscous fiber and the reduction in saturated fat and in adding plant sterols and replacing animal protein or carb with 30 grams of plant-based and weight loss, small amount counts. Then here is a very important slide because butter, coconut oil, and even palm oils, they are high in saturated fat, as you can see with the red boxes here. And so it's very important that we consider these when we're guiding our patients. And these are some slides on plant sterols, and which is very hard to get unless it is fortified. The second one, as I mentioned, was the nuanced triglyceride elevations. So as you can see here, it is very important that you refer to a dietitian because for triglycerides, very important that they get involved with the dietitian to get the personalized attention they need. And the last one is the nutrition and lifestyle interventions for combined dyslipidemias. So with that, I don't have time to cover the controversies, but I think in a way I have, because if you remember, I mentioned about the coconut oil and how that's so high in saturated fat. And we talked about the butter, that it's not really back. And this is the latest study by Zhang in 2025 that showed that replacing 10 grams a day of total butter intake by equal amounts of plant-based oil will reduce mortality, total mortality, 17% reduction, and 17% reduction in cancer mortality. Cardiovascular mortality was 6%, but it was not statistically significant. And the last controversy was the plant-based or the seed oils, because there's a lot of rumors going around that avoid seed oils, they cause inflammation and cytokines go up. But that's not the case, as we can see here in this Harvard study by Dr. Frank Hugh. And also in this study here, which is the latest study, 2025, where we can see the global burden of cardiovascular disease and future trends. And you can see how the omega-6 polyunsaturated fats, defined as less than 10% of calorie intake. Actually, the low intake was linked to 738,000 deaths and 18 million disability-adjusted life years due to CVD. So pretty important that people stick to their plant-based oils. And as you can see here, this is history that even Dr. William Harris, who is the guru of omega-3, you can see that he's said the same thing and back in an AHA presidential advisory, and so did Robert Ackle. And these are friends of plant seed oils, as you can see here. And this study also, this was also a presidential advisory that showed the same. So moving on, in summary, this slide will show you what to do, what not to do. And the final slide is to turn that pyramid that we didn't like upside down. Put the vegetables and fruits up with the fiber. And Melody, I know, is going to do a great job discussing this. And on the bottom of the pyramid, move those fatty meats, right? Okay, and cheese and so on. So the key takeaways are a healthy dietary pattern can improve dyslipidemia and other risk factors. It can also we can combine nutrition interventions to have the additive effects. And remember, interventions for triglyceride elevation require a lot of nuanced individualization. So remember to send your patients to the dietitian for those as well. And again, as you saw the data does not lie. MNT by dietitians has clear benefits for management of dyslipidemia and cardiometabolic risk factors. And these are links to all of those guidelines we talked about. Thank you so much for the opportunity to share with you.
Thank you.
Thank
Thank
you.
you so much. Very good presentation. We now turn to Melody Hermel, who's going to be talking to us about more things about nutrition. It's a big topic, very important. So Melody, take it away.
Can you see my slides?
Yes, we can.
And you're seeing the presentation. Okay.
Yes. All good.
Well, thank you so much for the warm welcome and for the invitation to be here. I'm really honored to speak alongside Geeta. I have no disclosures to report. My objective is to discuss the practical doctor-to-patient relationship and strategies to implement nutrition guidelines in the clinic. And I will also share useful nutrition handouts and tools to use in a busy clinic setting. So why should a cardiologist discuss nutrition? I remember when I was interviewing for cardiology fellowship, I was asked what I am passionate about. And I said, I want to be a cardiologist to focus on prevention, to counsel patients on nutrition and exercise and stress management. And so many people asked me along the way, why aren't you becoming a nutritionist? I was surprised because we know heart disease is the #1 killer and it's 90% preventable. And nutrition is the greatest determinant of our health. So I really think cardiologists should be leading the efforts in prevention and partnering with our registered dietitians, nutritionists on this effort. Why don't we always discuss nutrition? In a recent survey, 59% of cardiologists reported spending less than 3 minutes discussing nutrition during patient encounters, and 90% reported minimal nutrition education during training, with only 1% believing themselves qualified to counsel patients. Of note, the words nutrition and diet are actually absent from the 38-page ACGME training rubric for cardiovascular disease. And we know the reality. We're busy. We're seeing many patients in a short amount of time, and it's hard to add yet another thing to the agenda. So let's dive into a case. This is a 36-year-old female who came for cardiology consultation. She has a history of prediabetes, she is overweight, and a family history of premature coronary artery disease. Her cholesterol is 198, LDL 116, HDL 26, and triglycerides are elevated at 322. She told me her goal is to discuss nutrition to prevent cardiovascular disease. And the National Lipid Association actually gives us guidance on how to do this. This is a step-by-step approach, starting with identifying a specific nutrition topic, to assessing the patient's current knowledge and motivation and interest in making a change, and then moving towards setting specific goals and follow-up. And we'll go through each of these steps. I start the conversation with patients before I even meet them. I have a dietary questionnaire that I give to every patient, and I have an intake form which asks the patients to describe what they eat for breakfast and lunch and dinner. I ask them if they feel they need to change their eating habits, yes or no, and on a scale from 1 to 10, how ready are they to make that change? So 1 is they're not ready at all, and 10 is they're ready right now. This saves a tremendous amount of time in a busy clinic setting, and it's a natural way to start the conversation and focus the conversation. Here's an example of an intake form that you can use, and it has a list of foods, and it asks how often the patient is consuming each of these. And this is a graphic of the questionnaire that I'm using in my practice. And as an example, you can see it asks, how often do you eat leafy green vegetables? Daily, 4 to 6 times per week, 2 to 3 times per week, about weekly, rarely, or never. And it goes through and asks that same question for each of the food categories that you can see illustrated here. And using a questionnaire like this really allows you to be objective and collect specific details. Because without this, we would be asking patients, how's your diet? And they'd say, it's good. And that would be the end of the conversation. After you've identified specific health-related nutrition topics that are relevant to your patient and reviewed their current eating program, it's important to assess their interest, their motivation, their confidence to make a behavioral change. And you really need to start by asking for permission. I ask my patients, do I have your permission to discuss nutrition, to discuss your weight? You need to find out if this is even something that they want to discuss with you. Many of us are familiar with the stages of change model. You may have seen this with alcohol use disorders or with smoking cessation counseling. I use this same model working with patients on nutrition changes. We need to meet patients where they are, and we need to find out where they are. So maybe they're not aware of the need for change, or they're not interested in changing. They're pre-contemplative. Maybe they have built an awareness and they're not really sure yet if they're ready to take action. They're in this contemplative phase. Or maybe they've started to prepare. They're starting to take small steps. Maybe they're in an active phase and they're looking for specific behavioral changes that they can make. So it's very important to find out where your patient is. For example, with our patient, if she was pre-contemplative, if she didn't think nutrition was playing a big role in her health issues, we could ask her, what is going well with your current nutrition program? What don't you like about it? And we can get her talking about it and find out if there's anything that she doesn't really like. And we can try shifting the conversation towards contemplation. You know, what would it look like if you could change that? And how would you feel if you started eating these other foods? And this is really important to help patients, you know, if you have to start the conversation where they are, because if you start talking about putting things into action and they don't even think it's a problem for them, it will be very hard to have that conversation. So our patient actually said she was highly motivated and she's looking for specific tips and tricks, and she wants, you know, specific tools that she can use. So that's what I'd like to focus on now in our talk, specific goals that we can work with patients on to improve their nutrition. And you can use a sheet like this from CardioSmart to list a specific goal that you can ask about at follow-up visits. And make sure to use patient-specific health measures. You know, if their blood pressure's been an issue, dyslipidemia has been an issue, glucose, weight trends. Use those teachable moments to connect dietary habits and cardiovascular risk. Sometimes patients tell me, I'm not sure what my goal should be. I don't know what to put on the list. And so we try to anchor the conversation to what is most important to that patient. How do they feel in terms of energy, sleep, symptoms, daily function? Sometimes I give them examples of what other patients are working on. I give them a menu of options and they can choose which habit they want to focus on next. So let's go through some of those options. I tell my patients it's not always what we're eating that's a problem. It's often what we're forgetting to eat. And we need to focus on what to add into the diet. If you tell somebody, don't eat this and don't eat that and don't eat that, it's very restrictive. They can become easily discouraged. And when we focus on a positive approach of the foods to add in, the less healthy options naturally fall out. Another goal we can focus on with patients is to eat the rainbow. Vegetables contain the highest concentration of vitamins, minerals, and other protective phytochemicals with a lower caloric density compared with other foods. And when you eat more vegetables, you actually get to eat more food because of the lower caloric density. This concept of eat the rainbow increases biodiversity in the gut and supports the microbiome. So I tell patients, if you eat spinach one day, you eat kale the next day, you eat Swiss chard the next day, we're aiming to get 30 unique plant species in a week. As Geeta mentioned, fiber, fiber, fiber. That's what I'm always telling patients. Higher dietary fiber and whole grain intake is associated with decreased inflammatory markers such as hsCRP and IL-6, and substantially lowers the risk of inflammatory mediated diseases. And this fiber is coming from fruits and vegetables and whole grains. I recommend to my patients to eat 40 to 50 grams of fiber in a day, which is far more than most people are recommending or more than most people are eating. And of course, you have to add it in slowly. You can't add all of that in one day. When you eat fiber, you're eating the plant form of cholesterol. And as you can hear, this word phytosterol, that's the plant form of cholesterol. And the phytosterols compete for the absorption of cholesterol in the gut. And I often tell my patients, because many of them don't want to be on medication. Well, we can give you a medication that will block the absorption of cholesterol in your gut. Or you can up your whole grain plant foods, fruits and vegetables intake and block the absorption of cholesterol in the gut. So this is often a preferred choice for patients. We want to make sure our patients know what we mean when we say whole grains. And so if you look at this image here, the bran is the part of the whole grain that's protecting the seed. It has the fiber, the B vitamins, the minerals, and the germ is nourishment for the seed. B vitamins, vitamin E, minerals, phytochemicals. When we refine whole grains, we remove the bran and the germ, which are the healthy portions. And I tell my patients, when you're thinking about whole grains, think about the ancient whole grains. The farro, the buckwheat, the barley, millet, sorghum. Many of them haven't even heard of many of these types of foods. And when you're hungry and when your blood sugar is low and you're reaching for a food, another goal that I share with my patients is if you reach for white bread or baked potato or white rice, you're going to make yourself hungrier and lower your blood sugar even more. So we want to reach for foods that are lower glycemic index, foods that will bring up our blood sugar slowly and keep our blood sugar stable longer. When you eat these refined grains, your blood sugar goes way up, our bodies release insulin, your blood sugar nosedives, and then you're hungrier and you've got lower blood sugar. And I tell my patients, it's a marketing strategy that companies use, right? They put more sugar into the product and they make you hungrier. So you want to eat more of their food. Patients are often surprised when they hear that. This is a simple concept, another tool that patients can choose to use. And it's not perfect, but I think it's helpful. This is the less than 10 to 1 total carbohydrate to fiber ratio. So I tell my patients, if you're eating something packaged, look at the back of the package. Look at the total carbohydrate, look at the fiber. And the total carb to fiber ratio should be less than 10 to 1. And ideally, the fiber should be 3 or more. And if it doesn't pass these rules, then you shouldn't eat that food. Again, it's not perfect because we don't know what type of carbohydrate is this. Look at this product. It has 10 grams of added sugar. This rule doesn't really focus in on the amount of sugar, but I think it's a good, simple way to start and help people find more healthy options. Another goal that the patient might choose as their first goal they want to focus on is choosing better fats. Limit red meat, pork, processed meats, bacon, ham, salami, sausages, hot dogs, butter, cream, and processed foods that use palm oil or coconut oil. And use liquid vegetable oils instead of solid fats like butter or coconut oil. And we want to choose healthy protein. I think there's way too much emphasis on protein. Everyone's so worried about getting enough protein. We actually know that diets high in red and processed meats are correlated with increased inflammatory markers, markers of glucose dysregulation and dyslipidemia. And we've actually seen diets higher in red meat, especially processed forms, are associated with higher rates of cardiovascular disease, certain cancers, and all-cause mortality. And too much protein can actually push a patient towards diabetes. They're often surprised to find that out. So as Geeta pointed out, we don't need as much protein as we think we do. We need healthy sources of protein. We do need protein, but we really want to be emphasizing fiber, 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 not so much on the protein. So back to our patient. She decided that she wants to choose as her goal to shift from refined carbohydrates to whole grains. And she set the specific goal of adding in 3 servings of whole grains daily. And that was something that we could track at follow-up visits. Okay, so again, we're busy. We're seeing a lot of patients. We've got a limited amount of time. I want this to be very practical for you. So I'd like to share some handouts and tools that you can use in the busy clinic setting. So here's the concept of the healthy eating plate. And I tell my patients, look at your plate. Look at the plate and see, is there a vegetable on it? Is there a fruit on it? Do I have my healthy protein? Do I have my ancient whole grain? Do I have my healthy oils? Am I drinking enough water? You know, in America, we tend to eat a big steak, and then we have this idea of a side salad. And I think this term side salad, we need to get rid of it. The whole plate should be fruits and vegetables and whole grains. We shouldn't have this side salad concept. And here's another tool that you can use. You can find this on CardioSmart. There's many resources available. So know that these, sheets are out there. And I just think it's so important that you hand this to your patient, that the patient gets this directly from their cardiologist, that they see this is important to us, that it will directly impact their cardiac health. This is a tool that I use in my clinic. This is from the Tufts School of Nutrition. And I like this tool because it's very simple. You've got the 4 stars are the best foods. 3 stars are some less healthy features. 2 stars have negative factors, and 1 star has little nutritional benefit. And I tell my patients to take this out when you're in the supermarket and look at the 4-star section. Are you getting enough of these foods as you walk around the market? And we can actually write food prescriptions for our patients. If we actually give them produce prescriptions, this is some research showing that, in this study, 121,000 averted cardiovascular disease events. So with the right nutrition, we can have tremendous impact, and it can be very helpful in terms of cost saving as well. And this is medically tailored meals. In adults with serious medical conditions who've got 10 medically tailored meals per week for an average of 9 months, they were 49% less likely to be admitted to the hospital. So that was 2.6 million hospitalizations prevented because of healthy nutrition. And very important resource here on eatright.org. So not all of us have a registered dietitian nutrition expert like Geeta in our practice. And you can actually go on this website here, and you can see the red link up top. You click on that button, find a nutrition expert. You can type in your zip code and find somebody local to connect your patient with. I asked one of my patients who's been extremely successful in her nutrition changes to give me some guidance for other patients. And she had been through a big health event and decided to make some healthy changes. She said that she is now watching her saturated fat. That's a specific number she tracks each day to see how many grams are adding up. Reducing the choices, simplifying the meal plan helped her. Reprioritizing what was important in her life after this health event made a big deal. She decided to have a specific anchor. So for some patients, they'll have a certain image that they call to their mind. They picture their family, as they're making choices about which types of food to eat, and knowing, okay, my goal is to eat healthy so I can be there for my loved ones. Or having a specific mantra, saying to yourself, I have the power to change my nutrition. Having accountability, check-ins, reminders. I tell my patients to know the who, what, where, when, how, and why of what they're doing. Make sure you've got all the details worked out. Do you have the grocery list worked out? Do you know which market you're going to? Do you know which foods you're going to purchase? How you're going to make those? How do you work it into the schedule? There's so many variables beyond just knowing which foods to eat. And then being in the right environment. You don't want to be walking into fast food restaurants or places where you can't necessarily find a healthy option, and make it harder on yourself. And she said practical tips were also very helpful for her. So ideally, we would cook our own food, but if you're short on time, knowing that packaged vegetables are available, knowing certain things that she could buy from the market that she could warm up easily. And I'd like to make sure that we acknowledge that nutrition is shaped by more than just food. There are many other variables, and sometimes you need to figure out which of these issues is at play before you can even start the conversation on nutrition. If cost is an extreme barrier, or a patient is under tremendous stress, not sleeping well, trying to manage things at work or family, it's going to be very hard for them to shift their focus towards healthy nutrition. So some take-home points. Emphasize the importance of nutrition to your patients. This is our job as cardiologists, and we do need to take ownership of this. Ask permission from the patient, and that can really help to set the conversation off to a good start. Use the behavior change model. Send patients to a registered dietitian nutritionist, and I pick up the phone and I call them and I say, hey, are we on the same page? Are we giving the same advice? Because we don't want to confuse our patients with two different messages. Focus on plant-focused whole foods nutrition. And as one of my mentors taught me, eat foods that give rise to life. Plants, seeds, nuts, and other foods that nourish and sustain the body. If you're short on time, these are some simple messages from acc.org. Many of the things that we've been emphasizing today: fruits and vegetables, more water, whole grains, beans, cooking meals at home, choosing unsaturated fats. And I've tried to be very careful as I talk here to use the words nutrition and lifestyle and not diet. We're really trying to focus on sustainable habits for life as opposed to short-term temporary plans. Well, thank you so much.
Thank you so much,
Very good.
Dr. Hermel. Really wonderful discussion, and also thank you to Geeta. So we now have about a 10-minute discussion period. Maybe I could just start out by asking you, Geeta, how do we best communicate to our physician community and I'm actually cardiologists in particular about the resources that they have at their disposal, but maybe don't know how to get at them in terms of, in particular, in terms of registered dietitian nutritionists, and how to find one, like through the Academy of Nutrition and Dietetics. And kind of a second unrelated question is, what's the current status of the medical nutrition therapy bill, and how can we all help them advocate for that? So maybe I'll let you address those two questions there.
Thank you very much, Nathan. Getting back to how do we educate our cardiology community, our physician community on resources. I think as Melody showed the beautiful slide where it said, go to eatright.org. That's the Academy of Nutrition and Dietetics. And in that, there is a link to find a nutrition expert, which is a registered dietitian nutritionist by specialty and zip code. So if you look at those two, you'll find the ones that you're looking for. And they would be then in your neighborhood and your patient's neighborhood in that sense. So that would be very helpful. And you might recall, I think it was a year ago, that I made a handout for the American Society of Preventive Cardiology on just this, how to find a dietitian, how to partner with a dietitian. So I think that handout maybe needs some visibility at this point, right? So that, and then your second question was about the status of the bill. So the M&T Act, expanded M&T Act, was reintroduced this year. Originally, it was introduced in 2023. So it's, you know, how it takes a few years to get a bill to pass, right? So we're working on it, and it is a bipartisan, bicameral bill. So we're hoping that if we can get the, the ACC, American College of Cardiology, to also partner with the Academy. We already have 60 other partner organizations that have supported the bill. That would be very helpful to us, and AMA as well. These two have held back. They haven't supported our legislation yet. Not AMA and not
And I think
ACC.
you're in
ACC said
touch.
if AMA will support it, then we'll support it.
Yeah. No, I think that's very important. And, it's very important for our cardiology community to kind of lobby behind us. And I think, the key people with National California ACC Prevention Committee, and hopefully you've been in touch with them, but let me know if I can be of any help.
We have a great question from William Ock, which is, I think both of you could probably answer. How does the change in diet with GLP-1 drugs compare to MNT? So, Melody, Geeta, you want to take a shot at this?
Yeah, because dietitians are skilled at motivational interviewing. And if physicians want to get into it, then get yourself certification. And I'll give you a very quick example of that. Two typical questions I ask my patients are, the first question is, on a scale of 0 to 10, how motivated are you today to change your dietary habits? And usually they'll say, I'm a 9, I'm really ready, right? And that's why they came in to see the dietitian, right? Because that's a big effort to do that. So then I'll ask the second question, on a scale of 0 to 10, how confident are you that you can make the changes? And that's where they start thinking, and they say, Geeta, I'm probably a 6. Maybe I can do it, maybe I can't. So that opens the conversation to the barriers that get in the way. And that's what Melody was talking about too, about having open conversations, not closed conversations. So then we work through those issues, those barriers with the patient as their partners in a nutrition journey. Thank you.
And I can take a stab at the GLP-1 question too. I do prescribe them. I do use them in my practice for the right patients, but I think they have to be used very carefully and alongside the appropriate nutrition. I think that's very important. And often patients will tell me, well, I'm so full, I don't feel well on this medicine. I can't eat fiber now because I'm taking this medication. So it does become a challenge. But I think that they need to be used for the right patients at the right time, for the right amounts of time, and with the right nutrition program in the background. But I tell my patients is that even if we put you on medication to control your cholesterol or your blood sugar or help with weight management, that doesn't mean that we don't need healthy nutrition too. We know that nutrition helps to reduce inflammatory conditions, reduces cardiovascular disease, reduces major adverse cardiovascular events. In the studies, we see that immediately when patients change their nutrition program, and that's outside of the numbers. So we need that no matter what other intervention we're using.
Nutrition is very important in the patients on GLP-1s because that's one of the GLP-1 failures. When patients don't change their diet, they don't change their nutrition, GLP-1 isn't going to have the same effect. So great points. John Zay asks, what are your recommendations regarding organic food? Any comments?
I'll add a second part to that question is what's labeled as organic
Is it
really
really
organic?
Yep,
And
there you
there's
go.
some debate about that, whether if it's labeled that way in a supermarket versus getting your meat off a farm or something,
Yep.
I guess my thought would be better doesn't mean, better could be good, even if it's not the best. And everything we eat depends on everything else we eat. So patients will often give an example of what about an organic option, or what about, this particular food versus that food, or this type of nut versus that nut, or this oil versus that oil. And we can always strive for better, 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 get up to the best. But I think what we're looking at here to make these, overall changes to our nutrition program is everything we eat depends on everything else we eat. So again, is our plate well balanced? Are we getting enough of variety of all of the things we need? Maybe it's superior, I'm not sure, to eat organic foods, but if you get fixated on organic and you forget to have a whole grain and a vegetable and a fruit, I think getting the right balance is probably even more important. But that doesn't mean we can't eat organic foods. I don't have a particular stance on organic or non-organic.
Great answer.
any
Great answer.
thoughts on that?
So, there's the list of dirty dozen and the clean green, right? So you may want to look at that list and choose those organic foods that are part of the dirty dozen list that make that list. For example, but banana is in the clean list because it has a thick skin. So you may want to delve into that.
Good point. And we have one final question for you, Geeta. And I know you covered this a little bit, but maybe you can give a little more detail as to what referrals to registered dietitians are covered by insurance, and maybe whether I'm curious also whether certain insurances differ in their coverage, such as, Medicare versus Medi-Cal so we're
So,
curious as to your thoughts.
yeah, so again, it's getting better and better as the insurance companies are also realizing the importance of MNT. They've seen the evidence. We all see the evidence together. So it's improved, and in some states it's better than others. I'll say that too. But yes, Medicaid also, Medi-Cal also covers definitely for diabetes and kidney disease, but also for dyslipidemias and other issues, depending on how the physician who's referring writes it up.
That was actually
Yeah,
my
that's
question.
great. And then even private insurance, I'm curious if there's maybe better coverage, and ideally, I'm wondering if there's a sheet that is put together that talks about what coverage different the carriers and insurances provide. That would be very useful and something that we could promote from the California ACC, certainly. And we have something like this. It needs to be better put together, like on coronary calcium screening coverage, which is something that, I'm going to work on. But, I'm curious if that exists.
Yeah, the Academy of Nutrition Dietetics has a reimbursement, division. So I can get you in touch with them and they can educate us more on specifics by states, because there's a lot of this going on in different
Yeah,
states. The coverage is
great.
different. And so that's worth looking at. Yeah.
Yeah, many times
Because
when
I think,
you mentioned the coverage and you mentioned
Yes,
what the
I will
physician
get you
writes
in
in his
touch.
notes.
Yes.
So the thing is that sometimes certain words will automatically get things covered. So I don't know if either of you have those things that, failed diet or failed this, diabetes, what are some magic words that we clinicians can use to get a dietary consult in most insurances? Melody, you get some as well, I assume.
Great question. In terms of coverage, I'm not sure I know exactly what gets covered, what doesn't. I know we have in our group, we have a registered dietitian nutritionist we're able to refer patients to, which is very helpful. And they kind of give us some guidance and they'll assess the patient and, figure out which nutrition health related issue needs to be put, specifically for billing. So that I am a little bit protected from that, but I do take a look at, what many of our patients are struggling with. Is this a blood pressure issue? Is this a blood sugar issue? Is this a cholesterol issue? For any of these things, I'm sending them to physical therapy and nutrition. And, maybe you only think of physical therapy if they have a broken ankle or something like that. But no, if they've got high blood pressure, high blood sugar, I'm sending them to physical therapy and nutritionist.
Great. Nathan, any other thoughts?
I think this has been a very worthwhile webinar, and we've all learned a lot from both of you, Geeta and Dr. Hermel, and we want to thank you again, as well as our audience tonight for their participation. And we're always for the audience, we're always looking for suggestions for future webinars. So please do reach out to Dr. Baker or I should you have any suggestions. And I think with that, we have normally have these scheduled the second Wednesday of the month, right?
Yep.
Yeah.
Yep. So the next one's going to be September 9th. So the same link you used to join this webinar, you can use that registration to join the next one. So.
Okay. Thank you all again for participating. Okay.
All right. Good night, everyone.